Good morning, everyone, and welcome to this session of strabismus, which is a complex strabismus, or having dealt with the simpler form of the strabismus. We are now dealing with the paralytic and restrictive strabismus. I'm Dr. Swati Phuljhele from RP Center AIMS, and I'll be talking about management of sixth nerve palsy here. So as we all know, sixth nerve palsy presents as limitation of abduction, and there will be esotropia with the face turned towards the affected side. Its major differential include ESO-DRS and infantile esotropias with cross-fixation. So they are often confused as whether this is a DRS case or a sixth nerve palsy case. But if we look at the amount of deviation in the primary gaze, that will give us some clue whether it's a restrictive strabismus or a paralytic strabismus. In restrictive, generally the amount of deviation is much less as compared to a paralytic strabismus. As far as infantile esotropia is concerned, it's always important to check for the duction. So not just version, ductions have to be checked. Etiology include from all range of causes like microvascular occlusion, trauma, neoplasm, inflammation, or congenital. So this is a case where there was a risk factor of diabetes and patient had isolated sixth nerve palsy. Very simple case to diagnose, no problem there, and will have a good recovery. We all know that. This is another case, very interesting case. So it can be a manifestation of something very sinister. So 27-year-old female presented with just an inability to move left eye outwards for 10 days with a history of headache and fever. So on neuroimaging, this is what we get, an extensive inflammation involving all the sinuses of the brain. So sixth nerve palsy, one should never take it as lightly because it may be a manifestation of something very serious in the brain. Next, it could be a false localization sign in cases of raised ICT. So how do you neuroimage these patients? So depending on the age of the patient, the risk factors there, the involvement of other cranial nerves, other neurological features, you have to image the patients. But if patient is old enough and you know that's probably a microvascular occlusion, you may choose not to image. So coming to the indication for therapy, as already described by Dr. Digvijay. So it's the diplopia in the primary gaze, which is a problem, and a constant anomalous head posture you need to correct. So therapy can be non-surgical and surgical, as it has been discussed earlier also. We can also give Botox, as talked by Dr. Saurabh Jain, very nicely showing some cases. So the same thing can be given in the paralytic cases also. So here, this is a case of sixth nerve palsy, where you can see that the left eye had poor abduction, and after giving the Botox, the improvement, you can see the patient is very well aligned there. So if your Botox fails, what are your options? So there is whole range of surgeries you can do, as contrary to the third nerve, where you have very limited surgeries which you can do. Sixth nerve palsy has, because other muscles are very well functioning, you have whole range of surgeries there which you can do. So depending on the recovery of abduction, depending on the amount of deviation, you may choose to do a recession resection procedure or a transposition procedure. So the algorithm says that if you have a good recovery of abduction, you may choose to do a recession resection. If you have limited recovery of abduction there, depending again on the status of the fibrosis of medial rectus, you have to do whether you want to recess the medial rectus or not, along with the transposition surgeries. So here is a case where you can see that there is a left eye esotropia over there with abduction, no abduction limitation. It's recovered sixth nerve palsy. So doing a simple recession resection procedure, but it has to be a supramaximal dose. As converse to the conventional surgeries, where we limit our doses to maximal dose of 6 and 9 for MR and LR, we need to do a supramaximal recession resection procedure in these cases. Here is another case where it's a post-traumatic sixth nerve palsy, and you can see that the abduction in the right eye is significantly deficit there. But the FDT for MR is negative. So what's your choice? So in such cases, your whole array of transposition surgeries, you may choose to do a double vertical muscle transposition, or you may choose to do a single vertical muscle transposition. You may choose to do a full tendon transposition or a partial tendon transposition, depending on your need to do the MR recession and the amount of deviation. So this case, we chose to do a full tendon vertical recti transposition, and you can see that the patient recovered a good abduction there, as well as alignment also. So this is another case where you have post-traumatic sixth nerve palsy. Here also you can see that there is a severe abduction deficit there, and the FDT for medial rectus is tight. So what do you do now? If you do same procedure, if you do a full rectus transposition, you still have a risk of anterior segment ischium because you need to recess the medial rectus. So you have a choice here to do a partial tendon transplantation, or you can do a single muscle transplantation. So in this case, we did half-width vertical rectus transposition to lateral rectus along with the MR recession depending on the tightness. You can modify or you can augment your transposition surgeries with the help of posterior fixation suture, again depending on the amount of deviation and the amount of correction that you need post-operatively. More and more nowadays, the a single muscle transposition surgery is gaining popularity. You may choose to do it with adjustable medial rectus recession, or you may choose to do simply a transposition surgery, again depending on your deviation. So this is a case where we had done SRT, superior rectus transposition with the adjustable MR, because the deviation was quite significant. That was a large deviation with a large abduction deficit. The post-op patient was relatively aligned with good abduction recovery. Now this was a very interesting case. You can see here that this child has esotropia in the right eye with the abduction limitation, and also has bilateral inferior oblique overactions. So if we do we have to operate for the inferior obliques here because there is a significant V pattern, but at the same time we have our own concern that if you do superior rectus transposition, it will not only worsen the V pattern in the up gaze, but will also limit the elevation because both of the elevators will be involved. So the fundus here showed extorsion, so, confirming the inferior oblique overaction. FDT for MR is free, so what we chose to do is to do a right eye MR recession with bilateral inferior oblique recessions with inferior rectus transposition here. So this is the post-op results with good alignment and good abduction recovery with the collapse of V pattern. Modified Nishida is also an option in such cases where you can do it with and without MR recession depending on the amount of deviation. So in this study was published from our center regarding the adjustable MR recession with Nishida procedure, and a good correction was achieved. So this is a review article which has collaborated all the studies and given us the results. So we have seen that the full tendon double vertical rectus transposition is as good as single rectus vertical rectus transposition with or without augmentation suture. So to conclude, it's a commonly affected cranial nerve. One needs to rule out the intracranial lesions depending on the presentation. RNR surgery can be done if there is a good action or power in lateral rectus. VRT single or double depending on your choice and comfort you can do. Thank you.
Thank you, Dr. Swati. Yes. Can we ask one question? Okay. So,
thank you.